Hi, I'm Aubrey. I am an anesthesiologist at Mass General with a specialization in preoperative management of patients. So we today are going to talk about preoperative management of a patient specifically with type 2 diabetes. I have no relevant financial disclosures to this talk. And really my goal today is to take us way back to the biochemical mechanisms of these anti-hyperglycemic agents. So we're going to focus just on the medications today. With the goal really that from those biochemical mechanisms, we can get to good clinical judgment of how to manage these patients in the operative setting, both in the preoperative clinic when we might be seeing them and thinking about what should we do with your diabetes medications, as well as when patients come in emergently to our ORs and maybe haven't held the medications as long as we would have liked. How do we monitor them and how do we manage them? So we're going to go from the basic principles up to the clinical management today. There's a whole world of diabetes care and management out there to think about and be excited about. So today we're focusing on the drugs and type 2 diabetes, but don't forget there's type 1 diabetics, there's insulin, which we're not even going to touch on today. There's advanced technologies like glucose pumps and continuous glucose monitoring, insulin pumps, all of those types of fancy things out there. So never stop reading about it. It's super cool. And really, this is a huge problem. These patients are absolutely coming to our operating room because 42.4% of adults in the US are obese, and that number is only getting higher. And these obese patients are going to be at increased risk for type 2 diabetes, as well as all of their other metabolic syndrome type of things with their high lipids, high blood pressure, CAD, heart failure with reduced ejection fraction, heart failure with preserved ejection fraction. And you're going to see that some of these agents that we're going to talk about today are not just for diabetics, but are also going to be used in this obese population with these other comorbidities. So keep in mind, huge problem. And of this subset, 42.4% with obesity, turns out that there's 34.1 million patients in the US with diabetes. And again, that number is only growing, and about 90% of these are going to be type 2 diabetics. This represents 13% of all US adults, and again, increasing. So these patients are absolutely coming to operating rooms all around the country with us, and it's up to us to know how to care for them. So with that, we're going to jump straight into thinking about some of these agents. So hold on tight, and here we go. All of these things, if you miss anything from my lecture, can be found at least at a high level in this consensus statement from the Perioperative Assessment and Quality Improvement Society. So these are going to, if you have any questions like how long should I hold that medication or anything like that, these consensus guidelines are going to be a good place to start your review. So jumping in, we'll start with the most common, which are the Biguanide class. Really, that means metformin. And metformin is the workhorse of our type 2 diabetic management. So metformin is going to work by inhibiting hepatic gluconeogenesis. And it does it through, in particular, this enzyme here. This enzyme is the mitochondrial isoform of the glycophosphate dehydrogenase. And this is going to ultimately lead to inhibited gluconeogenesis and also an elevated lactate. So when you think about all the things that you remember from med school about metformin, that's kind of really explained right there. So it's why they end up with lower A1Cs, which is great, but it's why they also are at risk for what's called metformin-associated lactic acidosis. So that's really the big risk that we have to keep in mind with the Biguanide class in the perioperative setting. And so metformin is excreted fully by the kidneys. It is not metabolized at all in the body. And so if your kidneys take a hit, as they can in some of our bigger cases in surgery, then you get increased levels of metformin because they're not being excreted as expected. And if you increase your levels high enough, you can get toxicity, and toxicity manifests as lactic acidosis. It also can manifest as GI symptoms and things like that, but really the lactic acidosis is what we have most in mind and what's going to be most apparent to us. So we do recommend holding morning of surgery. And then you're going to hear this repeatedly from me throughout this talk. Really, this isn't based on a ton of evidence. This is an expert consensus opinion. We certainly know that in like the ambulatory setting, probably not actually high risk of lactic acidosis from those sort of cases. They're low hemodynamic shifts, low volume shifts, so probably not a huge deal. But we do recommend holding morning of surgery for metformin. We'll move on. So alpha-glucosidase inhibitors, an older class of medications, not as commonly used because it's just not quite as effective. But really the one that you're going to see is acarbose in this class. And so the way that these guys work is very different from metformin. So it has very different risks. And so these guys are going to work in the gut. And so what happens normally in the gut is that you have these long chains of saccharides, right? Things like starches. So your oligosaccharides, your polysaccharides, and they're not going to be absorbable. So they're going to need to get cleaved by this alpha-glucosidase enzyme. And when they get cleaved into the monosaccharides, then they get absorbed and you get that glucose load. And so the way that acarbose works is that it mimics those starch chains, but it isn't cleavable by that enzyme. So it just blocks the active site. And therefore, some of the starches and the glucose load that the patient eats is not actually entering the bloodstream. And so they're getting fewer carbs from a full carb meal than you might expect. These are very well tolerated agents, typically associated with just a little bit of like GI upset, things like flatulence that can usually be avoided by slow dose titration upwards. Unfortunately, though, they're just not as good as some of the other agents. So they will lower your A1C, but a Cochrane review showed that there's really no mortality benefit associated with acarbose or any of the other ones in this class. It doesn't seem to have the same effect on the other organ systems that our other medications that we're going to talk about later really do. So you might see it. It's not as common. It's fortunately relatively low risk. There's no need to cancel a case, for example, if a patient took it that morning. We do tell them to hold it the day of surgery, mostly because it just doesn't have any efficacy if you're not taking any carbohydrates in. So if there's no benefit, then any minimal risk is outweighing the no benefit. So we tell people to hold it. But again, I wouldn't cancel a case if they held it or if they did not hold it that morning. So alpha-glucosidase inhibitors, not super common, relatively low risk. Moving on. This one is another very common drug. So these are your sulfonylureas. Your sulfonylureas are also called your insulin secretagogues. And we'll see what that mechanism means. So these are glipizide, glyburide. They're very common medications, mostly because they're older. They've sort of been around the track and everybody knows them, is comfortable with them. They're also available in combination pills with metformin. So a pretty popular class. And like I said, they're insulin secretagogues. So the way that they are going to work is that completely independent of the glucose level. So whether the glucose level is 60 or 200, they're going to go ahead and they're going to bind and block this potassium channel in the islet beta cells of the pancreas. By blocking the potassium efflux, it's going to change the polarity of the cell, which is going to open these voltage-gated calcium channels over here, allow calcium influx, which is going to promote binding of the insulin vesicles and release of insulin. So this is glucose-independent insulin release. And now we'll focus on the glucose-independent part because that's going to drive our risks, and that's also going to differentiate this agent from other agents later in our talk. So the biggest risk associated with these, as you can imagine, is hypoglycemia. So these are definitely the patients that you need to monitor their blood sugars because in the fasted setting of surgery, they're the ones who are going to be at risk for hypoglycemia. So we absolutely do want to hold these day of surgery. Fortunately, the half-life is short enough that just holding, say, the morning of surgery is going to be sufficient to prevent hypoglycemia in the majority of patients. But if your patient did not hold, you either want to think about delaying the case or to really closely monitor their blood sugars in that setting. And so sulfonylurea is a riskier drug than the other drugs that we've seen so far in the perioperative setting, and that big risk is hypoglycemia. So now, again, kind of continuing with some of the slightly older agents, this one is an interesting class, the Thiazolidinediones. So unlike the insulin secretagogues that we just talked about, these guys are insulin sensitizers. And so the main ones that are available in the United States are going to be pioglitazone and rosiglitazone. Rosiglitazone is highly regulated by the FDA because it has a high incidence of cardiac adverse events. And so you probably won't actually come across a lot of patients on rosiglitazone. But pioglitazone is still reasonably used, again, in the United States. If you go to Europe and other countries, not so common to find these medications there. So the way that these guys work is a very interesting mechanism. So these agents are actually going to work again in the periphery because they're insulin sensitizers. And so they're going to interact with this receptor right here. So this is the peroxisome proliferator activated receptor gamma. And by interacting with that receptor, they're actually going to promote transcription of genes that are used for sort of insulin receptivity and insulin responsiveness. And so they've got a wide shotgun of effects. And that's probably what's going to drive a lot of the adverse effects that I'm going to talk to you about, because these guys are pretty reasonable about lowering your A1C, decreasing your insulin resistance, which is a driver of type 2 diabetes. But they also are associated with things like heart failure and volume overload and hemodynamic instability. Hence, they're not on the market in a lot of places, and they're not going to be something that you see very commonly. And if you do see a patient on these agents, you want to be thinking preoperatively, what's their cardiac status? How are they tolerating this medication? Is this a new medication for them? Because if it is, I would be very wary of keeping an eye out for fluid shifts, edema, heart failure symptoms, those types of things. If they've been stable on it for a while, it's probably less of a concern, but I would still really want to query their cardiac status on these agents. Otherwise, just close monitoring in the operating room with these patients. Again, the risks are fluid shifts and heart failure, but not usually so much in the acute setting. We tell people to hold day of surgery. It's a little more for a good measure, because you can imagine that's something that is interacting at the level of gene transcription and expression. A day, like a half-life to wash out the drug, is probably not enough to really change the sort of the effects that it's having. But we do tell people to hold day of surgery. We closely monitor them perioperatively, just as we would anybody else, for these sort of side effects. And again, there's not a huge harm signal specifically in the perioperative space with these agents. It's just a big harm signal overall. So nothing too special to do for them, but keep a close eye out and keep your antenna up. Fluid shifts, heart failure, those are the things that you're really going to be wanting to think about in these patients. And so these are the thiazolidinediones, an interesting class, not a super common class. And now we're going to move on to some of the, what I think are really exciting agents. These are all from about the last 15 years or so. And these get at really interesting mechanisms, sort of big changes to the metabolism. And this is where we're really going to start digging into medications that are going to have an impact on not just your diabetics, but the rest of your metabolic syndrome type of patients. And so the first one here is going to be your GLP-1 or glucagon-like peptide 1 receptor agonists. So anything that ends in glutide. Semaglutide is probably the most common. It's the second one listed there. These are the only agents that I'm talking about today that are not oral. These ones are injected subcutaneously. So semaglutide is popular because it's weekly. Liraglutide, for example, is a daily injection, so a little less popular. And so these agents are going to work on a system called the incretin system. So again, taking you way back to med school to think through this mechanism. But here's a little bit about how it works. So GLP-1 naturally is released from these enteroendocrine cells, so in the gut, and they're released in response to food. So these cells sense food, they release GLP-1. GLP-1 enters the bloodstream and goes to its downstream targets. Its biggest and sort of most pertinent to at least diabetic talk is the pancreas. In the pancreas, it's going to interact with different cell types and it's going to do different things. So this peptide is going to it's going to bind to its receptors on the beta cells, and it's going to increase insulin secretion and increase insulin biosynthesis. So you're going to get increased levels of insulin. And then you're also going to get binding in the delta cells. And through binding in the delta cells via somatostatin, it's going to activate these alpha cells to decrease glucagon secretion. And so these two things are going to lower blood sugar levels. And this is really going to work in a glucose-dependent fashion. So if you're taking these agents, but your blood sugar is 60, it's not typically going to lower your blood sugar further. So unlike the sulfonylureas that we talked about earlier, that are glucose independent, that will always just promote insulin release, your GLP-1 receptor agonists typically don't. It's more glucose dependent release, which is a really positive thing for decreasing the risk of these agents in our type 2 diabetics. And then there's also some sort of conflicting evidence that maybe this can increase peripheral insulin sensitivity, which is fantastic. And there's much stronger evidence that these can lead to things like gastroparesis and delayed gastric emptying, promoting feelings of fullness for longer, and also can decrease hunger through actually like a neural pathway. And so this is a very exciting thing and makes it so that we use these agents not just in the type 2 diabetes population, but actually in the obese patient population. So because, again, low risk of hypoglycemia associated with these, we can treat patients who are not routinely hyperglycemic with these agents to promote weight loss. And so you might actually start seeing your patients who are coming in for like bariatric surgery on, say, semaglutide. These were two very recent trials that both showed that semaglutide, both compared to a placebo and compared to daily liraglutide, was superior in promoting weight loss. And so that's an excellent agent for our obese population to be on to help medically manage their weight. Additionally, this is going to lower lipid levels. It's going to reduce MI, stroke, cardiovascular death. So it's a really useful agent. And I think that we're going to start seeing it more and more. Fortunately, it's also relatively low on the risk side. There's a low risk of hypoglycemia associated with it. So, certainly monitor, but probably not a high risk there. And then some patients do experience really significant nausea and gastroparesis from these agents. Again, partly because that's what the mechanism is. And so what I've personally found is that patients who have had those sort of effects are not on it by the time they get to me in the OR. They didn't tolerate it and they're not kept on it. However, if they are, you might think about holding this medication for a little bit longer. What we routinely say to patients who are sort of comfortably on it and stable at their dosing and all of that is just hold the dose day of surgery. If you're on something like the semaglutide, that is a weekly injectable. If it's due on the day of surgery, just take it afterwards instead of before, just in case you get any sort of GI symptoms. We don't want to increase your risk of aspiration in the OR. If you're somebody who is very sensitive to this, frequently gets nausea, GI symptoms, those types of things from these injections, maybe consider, if it's a daily thing, holding also the day before surgery. If it's one of the weekly injectables, maybe holding the injection just before coming to the operating room, something along those lines. But for the most part, these are pretty benign agents and really widely used, and I suspect going to be more widely used. Again, 42.4% of our population in the US adults are obese, and these agents are really good for helping to manage obesity and the attendant comorbidities. So stay tuned, but I suspect we'll see a lot more of the GLP-1 agonists. And now a very closely related category. So again, keep these two kind of in your head together because they work in the same pathway. These are your DPP-4 inhibitors or dipeptidylpeptidase 4 inhibitors. So these, your GLP-1s are your glutides, these are your gliptins. So sitagliptin is a really popular one. And these guys are oral agents. So unlike our GLP-1 agonists, which were injections, these ones are back to being oral, which always helps, I think, with patient adherence to medications. So DPP-4 inhibitors, they're going to work, like I said, in that same incretin pathway. So if we go back to this is just a different picture of the incretin pathway. Here's our enteroendocrine cell down here in the gut. It senses food and it is going to release GLP-1. That GLP-1 is going to enter the bloodstream and try to go to its end organs, but that GLP-1 is going to be metabolized by DPP-4, right? Dipeptidylpeptidase 4. And there's a large volume of DPP-4 in the bloodstream, such that your average molecule of GLP-1 circulates for about 1 minute before being consumed by DPP-4. So we can imagine that if we wanted to increase our activity of GLP-1, we could either inject some, as we're doing with the GLP-1 agonist, the GLP-1 receptor agonist, or we could give you something that keeps it from getting broken down, which is what we're doing here with the DPP-4 inhibitors. So those are going to block those enzymes. It's going to increase endogenous levels, circulating levels of GLP-1. And again, it's going to have similar end organ effects as our GLP-1 receptor agonists. So you're going to see lowering of your glucose level in a glucose-dependent fashion through insulin secretion, again, glucose-dependent. So low risk of hypoglycemia with these agents, especially as monotherapy. And I should put that caveat on everything. When I say low risk of hypoglycemia, I really do mean as monotherapy. When you start mixing up agents and mixing up mechanisms, that's when you increase your risk of hypoglycemia. So I will put that caveat on all of those statements that I've made about hypoglycemia. So low risk of hypoglycemia as a monotherapy. It has a little less of an effect as a weight loss agent and a little less of a cardiac protective effect compared to the GLP-1 agonist receptors. We don't know that we fully understand why. The body is very complicated and has a lot of compensatory mechanisms. It's also possible that because we're putting in GLP-1 agonists in more supraphysiologic dosing, maybe that's the difference. But either way, DPP-4 agents are very good, low risk of hypoglycemia, not quite as good at doing the other stuff that the GLP-1 receptor agonists are going to do, but getting to be more common, and I suspect it will get to be even more common as time goes by. We do recommend holding these holding this medication on the day of surgery, similar to what we recommend with the GLP-1 agonist receptors, but this is very, very much expert opinion. And I think that more people are coming around to saying, you know, if their diabetes has been very tough to control, or if it makes sense from a surgical point of view, like maybe we consider continuing these. So I certainly wouldn't necessarily just say blanket statement, cancel a case if they're on these and take it the morning of surgery. But our recommendation in our pre-op clinic and in the consensus guidelines is to hold this the morning of surgery. So those are your DPP-4 inhibitors. So GLP-1 agonist receptors, DPP-4 inhibitors are kind of working in that same pathway from slightly different angles. So similar things, lump them together in your head. But now we get to my favorite class of medications for diabetes. These are your SGLT2 inhibitors. So these are going to be anything ending in flozin, canagliflozin, dapagliflozin, empagliflozin, or tugliflozin. These are really fascinating medications. So they are going to work at the level of the kidney. So they work in the kidney at the level of the proximal convoluted tubule, right? So this is your sodium glucose cotransporter 2, or SGLT2. This is where about 90% of your glucose is reabsorbed back into the bloodstream, right? It's why you don't spill glucose in your normal day-to-day life into your urine. It's because of this, this protein right here. And so if I block that protein, now you're going to dump a lot more glucose into your urine. So these patients on these medications definitely have glucosuria. But what that also really means, because this is a lot of glucose being dumped, these patients almost shift their metabolism into more of as if they were on a keto diet. So they're going to start shifting from using glucose as a primary energy source to using ketones as a primary energy source. And just like a patient who might be on a keto diet, you're going to see that if you were to measure their ketone levels, you would actually get them in the millimolar range of ketones potentially, which is much higher than like you or I sitting here on a normal Western diet. So this shift to ketogenesis is going to have a huge impact on other organs in the body, right? So it is certainly going to help with your blood sugar levels because you're just dumping so much sugar, but it's also going to have a huge impact on other things. So in your adipose tissues, for example, it's going to increase lipolysis. It's going to decrease your overall body weight. It's going to decrease inflammation in the blood. It's actually going to increase your hematocrit. So patients with some anemia associated with chronic disease can see a bump in their hematocrit. On the blood vessel side, it's going to increase your vasodilation, improve your endothelial function, decrease your sympathetic tone, decrease your overall blood pressure. It is going to lower your A1C, but it does not cause hypoglycemia classically, and again, in monotherapy. It's going to decrease hepatic steatosis, which is wonderful. A lot of these patients have non-alcoholic steatohepatitis, and if it can decrease that amount of fatty infiltration, that's huge. And it's going to be hugely protective to the kidneys. It's going to decrease CKD progression. But it's also the other things to keep in mind with glucosuria, it's going to increase the risk of UTIs. So do be aware and ask your patient if they've got UTIs. Think about Foley's in these patients. Maybe you want to avoid, if you were on the fence, this could push you to not doing it because all of that glucose in the urine is a great setting for bacteria. And then remember that glucose is a diuretic. So while that sort of volume flush through the kidneys might protect the kidneys, they are going to be body water down, and they're going to be potentially plasma volume down. And so these patients might need a little more volume than you would otherwise anticipate because this has been acting somewhat like a diuretic. all of these impacts on the peripheral organs have a great impact on the heart. It decreases hypertrophy, can actually promote remodeling. It decreases the preload, the afterload. It gets the heart onto a happier part of its Stirling curve. It can be really quite good. And so in the early studies, every agent coming out for hyperglycemia treatment needs to also have an assessment of cardiovascular risks. And they actually found that these patients were doing better cardiovascularly with these. And so there was a large trial. This is the Emperor Preserve trial, which I highly recommend reading. So this looked at patients who had heart failure with preserved ejection fraction. So remember, this is the majority of heart failure patients have HFpEF, not HFpEF, right? They don't have a reduced ejection fraction. The majority have preserved ejection fractions. There's been nothing that has been shown in that HFpEF population to decrease mortality or decrease heart failure exacerbations until now. So empagliflozin was tested in non-diabetic patients with HFpEF and was found to decrease cardiac mortality and decrease cardiac admissions for volume overload, which is huge. So in this very large population, because obesity is a risk factor for developing HFpEF, and we have a huge obese population, in this population, we now have something that is evidence-based that can improve their mortality and improve their disease state in a way that we've only seen before for HFrEF patients. You can bet that more and more patients are going to show up to your ORs on SGLT2 inhibitors, and they may not even be diabetic because of this study. So keep that in mind, because it turns out that SGLT2 inhibitors, while they're wonderful, have a huge adverse event risk. And that adverse event is euglycemic diabetic ketoacidosis. Right? These patients are in a ketogenic state anyways now, and you put them through the stress of surgery, the volume shifts of surgery, and you can actually end up profoundly acidotic. And this happened quite often. We had a huge incident of it at our institution where a patient ended up postoperatively with a pH of 6.9 from this. So the FDA just over a year ago, I believe it was last summer, or last spring, came out and said that all SGLT2 inhibitors must be held for at least 3 days for canagliflozin, dapagliflozin, and pagliflozin, and 4 days for tugliflozin. It's got a slightly longer half-life, to ensure that the body has essentially switched its metabolism back to its regular metabolic state and out of that ketogenic state, to prevent this euglycemic diabetic ketoacidosis. And so you really need a strong pre-op system in place to ensure that you have reached all of your patients on these agents. And trust me, there are going to be more of them, and they're going to be increasing. And you really don't want to bring them to the OR unless they've appropriately held this medication. So perioperative use. The risk here is euglycemic ketoacidosis, which we just harped on. So we're going to hold 3 to 4 days prior to surgery. And this is really the only agent where I can say, like, look, I have reasonably good data, and I can say that this is definitely the right thing to do. If your surgery is emergent and your SGLT2 inhibitor therefore hasn't been held, right? Patient with HFpEF comes to the OR for an emergent XLAP. It happens all the time. You're going to want to keep a very close eye on them. Look for signs and symptoms of DKA. It's going to be things like tachycardia, hypotension, just general hemodynamic instability. It's going to be nonspecific. So monitor your BNP for your anion gap. Monitor your ABG for your pH. You can certainly follow serum ketone levels. I know at our institution, it takes a long time to get a beta hydroxybutyrate back, but you absolutely can. If you start to see an anion gap widening, if you start seeing acidosis, treat with fluid, insulin, and glucose to maintain euglycemia per normal DKA protocols. But again, I can't stress enough, these patients will be euglycemic a lot of the time. So it's a subtle diagnosis, but it is one that you absolutely should not miss because it is easily treatable, but it is devastating if you do not treat it. So SGLT2 inhibitors, absolutely going to see a lot more of them. Absolutely a risky thing for the perioperative period. And it's incumbent upon us to know how to manage these patients when they come to our ORs. So those are the classes I wanted to cover. Those are your most popular classes of medications that you're absolutely going to see. There are a couple other classes, none of them are quite as exciting as SGLT2 inhibitors, for example. And you can certainly read on your own if you have patients that you see on those other sort of agents. So I just want to leave you with the idea that these patients are here. their numbers are rising, and they're only going to continue as the number of patients with obesity and diabetes continues to climb, and as the indications for these drugs continue to broaden. So you're absolutely going to see these agents. So remember, hypoglycemia goes with sulfonylureas, lactic acidosis with metformin, which is our biguanide, ketoacidosis with our SGLT2 inhibitors, and fluid shifts with our thiazolidinediones. Those are the things I want you to remember and really take away from this, because those are the things that you need to be watching for in your patients. And of course, there is so much more, as I said at the start, to diabetes care in the perioperative period than we can cover in 30 minutes. So please read up on these other topics on your own. And thank you so much. I will take any questions now.